Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello. Thank you for joining us for today's webinar on making sense of PDGM clinical groupings and comorbidity adjustments. My name is Heather Auger, and I'm on the communications team here at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from Nanette Minton. Nanette has been in home care since 1997. She has served in a variety of roles, including clinical, administrative, consulting, education, and agency startup and development. She currently serves as the Senior Clinical Coding Manager for Mac Legacy. Nanette provides day-to-day coding and quality support to the home care and hospice agencies receiving coding services. Nanette's experience in the industry gives her a unique perspective and allows her to provide coding and audit knowledge firsthand to clients. Welcome, Nanette. Now, before we begin, a few housekeeping items. Your phones have been muted, but we invite you to submit questions for Nanette through the questions feature on the control panel. We will follow up with you after the webinar to respond to all of your questions. Slides from today's presentation, along with the recording of the webinar, will be available after the webinar and will be sent to all who registered via email. The slides are also available in the handout section of the control panel and will be posted on axxess.com. Nanette, over to you.
Thank you, Heather. Good afternoon, and thank you to all of those joining us. I hope to provide a little bit of information for you this afternoon as we all try to conquer PDGM. One of the things I said was to try to look at giving you information if your agency is really struggling with how to interpret the outcome of coding and what this has on your case mix weight, and to really understand some of those things. So we're going to begin to break it down a little bit. Our objectives for this afternoon's education session are to enhance the knowledge of the learner on the impact of coding on clinical groupings and comorbidity adjustments, as well as to remind the learner on ethical coding practices and to determine which codes apply and how they interact to affect reimbursement. I'm sure many of you have seen this screen and seen this screen. And we know under PDGM, agencies must plan, deliver, document, and bill for care twice as often. That initial wrap is going to occur and does occur in a much shorter time span now, and you're doing double the work to do double the billing. So that's been a challenge for everybody. We know that PDGM is going to be based on the following 5 factors: episode timing. Is it early or late? Admission source, community or institutional. And then each of the assessments or the 30-day period you're billing for is going to be divided into 12 subgroups determined by that primary diagnosis. There's also a functional level that is identified by 3 groups: low, medium, or high. And this will all make sense as we get through if you're not familiar with how this all comes together to determine that HIPS score. Then you've got your comorbidity adjustment: none, low, or high, determined by secondary diagnosis. And we're going to spend some time talking about that as well. One of the things that's been really fun, if you've been following these webinars on this series, is that part of what we've tried to include is to understand destination success. So as I've said to my friends and my cohorts as I've been speaking, I've tried to make a little bit of this fun. So I've got 2 or 3 location destinations we're going to take a 2-second side trip to, so that you can put your mind at ease and pretend like you're on vacation for just a moment. So this is Myrtle Beach, South Carolina. It is one, and because today we're actually going to be talking about a couple of the Travel Channel's top 10 travel destinations. So if you did not know that, this Myrtle Beach actually comes from the name of it comes from thousands of wax myrtle trees that used to line the beach, not the big showy crepe myrtles that we all think of. And it's hard to imagine that when you stand on that beach and see all those high-rise hotels, that the oceanfront used to be essentially empty before 1901, when the Seaside Inn was that very first hotel in that area was built. The other thing is in 1901, a plot of oceanfront land cost $25, and you could get another plot of land for free if you built a house on the first plot. Aren't we all cursing our ancestors for not buying that property now? Anyway, just a little bit of fun there. I think one of the things that becomes difficult when you're trying to look at an assessment and determine how to put all the pieces together from a coding standpoint, to marry the billing, to marry the face-to-face, to match the order the physician sent along with the history and physical, and the OASIS assessment. You've got all these pieces of the puzzle that you're trying to put together. So you have to know no symptom codes. Most of us are pretty familiar with that, although we're going to talk about those a little bit more. Is that primary diagnosis accepted under PDGM? And I do want to make it a point to say here that it's not that you can't ever use symptom codes or that you can never use codes that are not acceptable as primary. You just can't put them in the primary spot. And of course, you should never code things that are inherent, symptom codes that are inherent to disease processes. For example, you would not want to code edema with a CHF patient or shortness of breath with a COPD patient. Have we also identified the diagnosis that would be the focus of care for that episode? You have to think about, what is my skill for this 30-day period? What am I doing? What are my goals? And do those all line up with that initial diagnosis that's on that plan of care? And of course, if it's a start of care, does that match the face-to-face? And sometimes you have to consider probing to find that additional diagnosis. So what does CMS expect? Well, they state that they're really looking for specificity and granularity of ICD-10 diagnosis codes. And they say this will allow the opportunity for home health agencies to improve their diagnosis code reporting to more accurately reflect the reason for home health services and other conditions that affect the home health plan of care. So if the supporting documentation from the certifying physician or the acute or post-acute care facility is lacking specificity, then the home health agency would be expected to query and to go back to those providers in order to get more specific information to address those home health care needs. Now, remember back when I guess it was a couple of years ago, when they said, oh, well, they're not ever going to let you use any unspecified codes. Well, I want to put your mind at ease, because although we want to have the absolute best specificity, there at least is some reasoning to this. So for example, if I'm coding a chart and I get congestive heart failure, but I don't have, whether it's systolic or diastolic, or I don't have some other wording that would help me determine the type of congestive heart failure, I know that the agency is still going to get credit for, in points related to that diagnosis if I choose the I-50.9, which is just the unspecified congestive heart failure. So you really kind of have to know what codes are okay to use like that and what are not. So I would encourage you, whether you have an in-house coder or you do outsource coding, that you have a plan in place to make sure that you understand all of those things. So what do we code? Because one of the variables in the PDGM case mix adjustment is the clinical grouping. CMS really believes that home health agencies are going to be more comprehensive in their assessment of patients and to identify all diagnoses to determine the individualized plan of care needs, and that those would be addressed on the home health plan of care. And really, this improved diagnosis reporting is going to allow the agencies to better paint the picture of their patients receiving home health services. So on this slide, I've given you 3 different sources and thought points on how do we code. So more specific and accurate diagnosis reporting to identify those conditions that affects the home health plan of care and to support the need for those services. And the COPs, the conditions of participation at 484.60, actually require the home health plan of care to include all pertinent diagnoses. So it's good to be aware of that. If some people say, well, I don't have a goal for every single diagnosis. Well, I understand that, and I'm not saying you have to have a goal for every diagnosis, but the COPs do say that the plan of care should include all pertinent diagnosis, and that you're required to consult the physician if there are any additions or modifications to that plan of care, and that obviously the physician would have to agree with that. So because of the inclusion of the clinical grouping and all the case mix groups, CMS says they believe that the home health agency documentation would improve, and we would have all these, a better picture of what's happening with the patient based on the coding, and that diagnosis and coding would accurately reflect patient characteristics. The majority of the R codes, those are usually symptom codes, as opposed to diagnosis, are not appropriate as principal codes for the grouping home health periods into clinical groups. CMS says the use of symptoms and signs and abnormal clinical and laboratory findings is going to make it difficult to meet that requirement of that individualized plan of care as required by 484.60. And it says clinically it's important for the providers to have a clear understanding of the patient's diagnosis in order to safely and effectively furnish home health services. So saying all that, what are the goals of the accurate coding? Well, obviously, number 1 is to prevent RTP. We don't want anything to be returned to the provider. We want to identify all the comorbidities so that we can get a comorbidity adjustment. And we want to ensure accurate reimbursement. If you do not have your coding done correctly, it's very likely you could be leaving money on the table and your agency might not be getting the reimbursement that they need based on that. Now, your coding needs to be ethical and accurate. We would not ever, from my clinical standpoint, you would never want to code anything that would be considered upcoding if it's not the focus of care. And we'll talk a little more about that later, a couple of examples of what that might look like. But we want the correct coding to result in episode payments that more accurately reflect the severity of that patient's condition, to reduce the number of claims returned, and to capture population health data. So, CMS is always capturing data. So anything we use at a later standpoint, if we're not going to the nth degree to make sure that we are more accurate in what we're doing, then it seems, if history repeats itself, that later on in the future we end up having issues with that data, and that data comes back to haunt us if we've not been completely accurate in that. So looking at sequencing, what is the focus of care? What other diagnosis may impact or be impacted by that care, even if there's no active treatment? So you really have to prioritize the care. And as well, only the assessing clinician can determine primary and secondary diagnosis in the symptom control rating, and the coder assigns the codes. Now, I know in some of the coding that I do on a day-to-day basis, in order to help agencies, we don't mind entering a default symptom control rating, but it's the clinician's responsibility with coordination through that agency to go back and approve that coding. So that has to be something certainly that's looked at within the agency administration to determine the best method for your agency. If you're not familiar with coding a lot, you will you might not have heard of the coding clinic. So I always like to kind of back up and say, you know, there is a method to the madness. There is actual guidance on a lot of the things where coders are not just pulling some of the information out of the air. So the American Hospital Association Central Office is the official U.S. clearinghouse on medical coding for the proper use of the ICD-CM system. And that one is for hospital providers, and certain, the level 1 is for hospital providers. Then there's a level 2 that are codes for hospitals, physicians, and other healthcare professionals. And so this governing body essentially publishes the coding clinic quarterly and will ensure that that published advice and guidance is sent down and established those national consistencies of the coded data. So it is a very organized system. And keep in mind that the ICD-10 code set that we use in the United States is actually an adaptation of the one from the World Health Organization. It looks a little bit different as compared to the ones used, let's say, in Europe. Just a word about non-specific referrals. So, you know, what if the physician is in process of determining a more definitive diagnosis? And I find this happens many times with, in addition to coding home care patients, but in coding hospice patients, because you might have a lady who's 97 years old who is getting pneumonia multiple times, no diagnosis of heart failure, no diagnosis of dementia, but, you know, definitely is declining. And so you have to really determine and work with that physician to come up with the correct diagnosis. And so sometimes as that agency, it's good to be aware of other codes or things that you could use to suggest to the physicians. So CMS says, what if that physician is in the process of determining a more definitive diagnosis? Well, they feel like that by the time the patient comes to home care, that really they should have already determined some kind of diagnosis. And we know, though, however, because we're dealing with a very aged population and a lot of people with these chronic illnesses, they don't always want to get that specific diagnosis based on the symptoms they're having. So that can definitely be a challenge. But obviously the goal of home care is to get as much information as possible and to make that as accurate as possible. Again, we've mentioned symptom codes, and CMS says that they do not believe it's appropriate to include symptom codes. Part of the committee that went to CMS said, look, these three really we should have and be able to use from a coding standpoint: bradycardia, altered mental status, or dizziness. And they said, no, we think there could be multiple reasons for these symptoms, and those are not appropriate as primary. What they did finally agree to, however, is, and this is the only R code from that section of unspecified codes that was added, and is a neuro rehab clinical grouping, and that would be all of the dysphagia codes. And the reason they did that is they found that in a lot of cases, there were no other specific identified cause that they could necessarily attribute to this diagnosis. So they knew that they needed something additional to be able to show that. Now, I will tell you, repeated falls, this is definitely one of those codes that I think that they should have absolutely included. But the coding guidelines state to only use this when a patient has recently fallen and the reason for falling is being investigated. So just because the patient falls a lot and you know they have, let's say they have dementia, which usually leads to some type of gait or abnormality as that disease progresses, you would not want to use this because that is sort of an expected part of that disease process. But you would use the Z91.81, the history of falls code, to reflect that. All right, and this slide actually just goes over what I just stated, that history of falling is a secondary diagnosis to describe the patient has fallen in the past and is at future risk, would be appropriate to accurately describe the patient's need for home health services. Now, when you look at sequencing, you could actually put this code, let's say the primary code is Parkinson's, and the Parkinson's is beginning to be more advanced and you need some therapy in there. Obviously, Parkinson's in and of itself is going to be appropriate for therapy, and you wouldn't need an additional code. But if you put history of falls underneath Parkinson's, it really more clearly helps paint the picture of what's happening with that patient. So just a thought process on that. I want to take just a minute to talk about muscle weakness. This was a code that was used and unfortunately overused and abused in the home care setting. So it's significant to note that this code was originally added to the code set. A group of neurologists believe it was necessary to have this specific code, indicating some type of muscle weakness. And really, there are a lot of people who agree that this diagnosis lacks specificity and that it would not be deemed medically necessary to have home care based on this. But when looking at a patient, for example, that had a history of pneumonia or had pneumonia, but the pneumonia is all but resolved, but they're left with this overwhelming weakness, that's one of the things that I know part of the committee went back and tried to get CMS to understand about this diagnosis. And CMS said, you know, with respect to the use of this code, we understand that sometimes this is used as a code to support medical necessity. They don't believe that this particular code is appropriate to group as a primary. So, like I said, that was unfortunate, but I wanted to actually mention that a little bit. With our new system under PDGM, you know, under our previous payment system under PPS, we looked at and really the top 6 were the ones that when you looked at what were essentially billable codes. Well, now with PDGM, you've got the primary diagnosis that falls in a certain clinical grouping, and we'll get to more information about that here shortly. And then you've got diagnosis slot 2 through 25, where you will be putting other diagnosis codes. And the sequencing should really be based on what you're focusing on mostly. But from a payment standpoint and a comorbidity adjustment standpoint, it doesn't matter if you had COPD in slot number 25 or slot number 2. So just keep that in mind. But again, you would want to have the sequencing most accurately reflect in the top 10 the things you're really focusing on. I mentioned the COPs earlier, that 484.60, but there's a couple of other places where it helps you clarify, well, what are other diagnosis codes? What does that mean? So you've got the coding guidelines, and then you've got the OASIS manual, as well as the COP. So really any condition that exists at the time of home health admission, that develops during the course of a home health plan of care, or that is going to affect the care planning, should be coded. So is it going to affect or potentially affect that plan of care? Even if that care only includes observation and assessment or teaching and training. something to look at for sure. Okay, clinical grouping. So PDGM requires that each 30-day period is going to be categorized into one of 12 clinical groups based on that principal diagnosis that's reported on the claim. These groupings are designed to capture the most common types of care provided by home health agencies. And if a primary diagnosis code is used that doesn't fall into one of these clinical groupings, then that claim is going to be rejected or returned to the provider. Now, most softwares have been updated with some type of scrubber in the EMR where you can look and it'll automatically tell you and look at that rejection. So something to look at for sure. So this is a slide that was put out by CMS during its initial education regarding PDGM. And on the left here, you'll notice that it has all of the clinical groupings listed. And then on the right, you have the primary reason for home health encounter that they would expect to see for that clinical grouping. Now, that doesn't mean that you couldn't do therapy on a surgical aftercare patient just because it doesn't say therapy for a musculoskeletal condition under MMTA surgical aftercare. It was just more of a suggested group of what you would expect to see based on those diagnoses. So this next slide is a tool that a friend of mine who I work with put together. She's and so really it's a PDGM base rate revenue by clinical group. So what does this mean? So these calculations do not account for additional case mix adjustments such as the MSA, rural add-on, quality reporting, that kind of thing. And obviously the final payment could be affected by several percentage points depending on the characteristics of your agency and other factors. But that lowest calculation at the top left under complex nursing represents a late community with a low functional impairment. The highest calculation at the bottom right, the 3435.41, represents an early institutional with high functional impairment. And the calculation is based on the base rate revenue for each 30-day period multiplied. So it's your case mix weight multiplied by that base rate, which was 1864.03 for 2020. And so that case mix weight is going to determine the HIPS, is determined by the HIPS code of each 30-day period. And it'll make a little more sense as we get further along in here. But I wanted you to see the range of how that might look. So as you can see, wound grouping, especially for someone who has a lot of functional issues who just came out of the hospital, the musculoskeletal or neuro rehab or wound patients are going to be somewhat higher paying groupings. Okay, let's take a mental break for 2 seconds here. I told you that we are in the middle of destination success. As we move forward here, we're about halfway through. And if you did not know that the Colosseum in Rome was commissioned around 70, the year 70 by the Emperor Vespasian, and was actually called the Flavian Amphitheater. And actually a giant statue of Nero once stood nearby. Thought that was really interesting. And it was built on a former lake. So I didn't know any of that when I was looking up these facts for this presentation. It was actually constructed in about 10 years, which for that time period and this level of architecture is pretty amazing. It was actually the largest amphitheater ever built, had a seating chart. It could actually seat 50,000, and of course hosted a lot of the gladiator fights that we think about that. So kind of just interesting history there. Again, on one of those top 10 destinations in the world as we try to give our mind a rest here. Okay, let's look at a couple of coding scenarios before we get into some specifics on clinical grouping and comorbidity adjustment to help us here. So Mr. Jones is a 68-year-old male. He was just discharged from rehab after hospitalization for Parkinson's. The neurologist adjusted his levodopa and has ordered skilled nurse and physical therapy for assessment, medication compliance, and to help with the gait issues related to his Parkinson's. He also has a physician-confirmed diagnosis of dementia, hypertension, CKD, and BPH with urinary retention and difficulty swallowing. So, if we were to code this, this is what it would look like, and this patient actually falls into that neuro rehab grouping. We have the dementia coded underneath the Parkinson's because there's no other stated cause of the dementia, so that would be assumed to be related to the Parkinson's. The same thing with the hypertensive chronic kidney disease. And of course, we've got the difficulty swallowing as well. Our next scenario, Mrs. Smith was referred to home care after an acute hospital stay for UTI related to her Foley catheter. She went to rehab for weakness related to the acute kidney injury from the UTI, but both the UTI and the acute kidney injury are resolved. But the physician had ordered monthly Foley changes. The patient also has emphysema with chronic obstructive bronchitis, diabetes controlled by oral agents, and uses oxygen at bedtime. This particular patient is going to fall into the complex nursing grouping with the Z46.6, the focus of care being management of that Foley catheter. And then, of course, we've coded our COPD. And the reason we coded COPD, the J44.9 versus J43.9, would be that it's listed as chronic obstructive pulmonary disease. If it was not listed as such or didn't say that, but only stated emphysema, we would be using the J43.9. And, of course, the rest of those are fairly self-explanatory on the reason they were coded that way. So what do we do if we receive a referral for a patient who on the order states repeated falls, history of prostate cancer? Don't you love it? Because that's the real world. And I will just say that's one of those cases that you have to talk to the physician and let him know what's going on with this patient and query the patient a little bit. You know, the patient may say, well, I've got this pain or that pain, or I've got arthritis. But then you would want to go back to the physician and ask, do you have a confirmed diagnosis of arthritis? I don't really have anything that I can use. And once you usually understand that explain that to the physician, particularly when you're trying to determine the diagnosis, because what they've given you is not appropriate as primary, you can come up with some other things to code. One of the things that I wanted to mention on muscle weakness is if you are getting referrals for that diagnosis, you can certainly look at muscle wasting or muscle atrophy as something that would be helpful. Okay, comorbidity adjustments. Under PDGM, there's 30-day periods that are categorized by comorbidity adjustment. So under PDGM, you've got 30-day periods that are categorized by comorbidity adjustments. And those are based on presence or lack of secondary diagnosis. So you're either going to have none, low, or high comorbidity adjustments. Now, you can only have one adjustment per pay period, no matter how many may apply. Okay, so while the primary diagnosis determines that clinical grouping, the secondary diagnosis can also impact that resource use and certainly is taken into account So let's look at that. So I mentioned that a 30-day period cannot have both a low and a high comorbidity time. If the 30-day period doesn't have reported comorbidities that fit into one of those categories, it would be assigned a no comorbidity adjustment. I don't know how many of you have seen this comorbidity adjustment subgrouping table, but to really understand this, so you have your, under PDGM, you have your primary clinical grouping, that whole list of diagnoses that we looked at earlier, or list of sequencing. So for example, it would be complex nursing, MMTA aftercare, whatever that primary clinical grouping is. And that is for slot number 1. So then you've got slot number 2 through slot number 25. If you have any diagnosis in slot 2 through slot 25 that falls within this group, then you're going to get a low comorbidity adjustment, which means you're going to get a little bit of bump of money for that 30-day episode. And you'll notice that, for example, if you have Parkinson's disease, or you have late effect of a stroke, diabetes, heart failure, then you'll get that low comorbidity adjustment. Now, I will say that, and this can be a little bit confusing, so if you have any questions, I have my email at the end and you can send me questions on this. But if you actually have any diagnosis in that primary slot, and let's say the comorbidity subgroup is the same as, so it's got its primary slot, and then you've got the comorbidity subgroup. If those end up being the same comorbidity subgroup, let's say you've got a cerebral 4 in slot 1 and a cerebral 4 in either slot 2 through 25, you're not going to get a comorbidity adjustment if at all, even though it falls into the low, if it also is in that primary slot. So I know that can be confusing, but that's not really in any of the education out there. And I wanted to be sure I mentioned that, because if you use the PDGM grouper, and I've got a couple of slides here in a minute we'll go over, you can really look at that and see what I'm talking about. So for high comorbidity adjustment, you have to have 2 diagnoses that combine together to create that adjustment. And the way this works is you've got up to 31 slots here. You've got behavior 2. So if you had bipolar, and then you had something that falls into a skin 3, then you would get a comorbidity adjustment. Or if you had, let's see, on number 4, comorbidity subgroup interaction number 4, let's say you had the late effect of a stroke, and then you also had heart failure. That would get you a high comorbidity adjustment. All right. Now that you've had 10 seconds on the beach, we're going to get into some of these grouping examples. And so these are actually ones that I have coded, and just to give you an example of what this looks like. So this particular patient has surgical wounds, non-surgical wounds. Oh, there we go. Surgical wounds, non-surgical wounds. And on number 3, I promise that's not my misspelling. That was within the software. And so this patient has venous hypertension, and they have non-pressure chronic ulcers. They have rheumatic insufficiency, AFib, PVD. So when you look at the HIPS code, and so what I did is I took all of the information from this patient's OASIS, and I plugged it into the grouper tool that CMS has to show you this example. Now remember, when you're looking at the HIPS code, That 2CB21 is then going to translate to a case mix weight, which is the 1.6219. And that is what is multiplied by that base rate to get your 30-day payment amount, obviously with a few adjustments, as we talked about earlier, that are not included in that. Because it would be different based on where your agency is located, your MSA, and those various things. So the first position is source and timing. So is it early or late? Is it institutional or not? And then the second position, clinical grouping. Now the clinical grouping, this is C is the wound, so it falls into the primary wound. And so they're going to be categorized as A through L based on what, I wish I could have a show of hands based on what class, but it's based on that clinical group. So the Z4801 puts it in the wounds grouping. Then you've got the third position is that functional level. Okay, and the functional level is going to be based on those OASIS questions, M1033, M1800, through there. And you're going to have either A, low, B, medium, which is this patient, or C, high. Then the fourth position is where you're going to see your comorbidity adjustment. 1 is none, 2 is low, 3 is high, and then the fifth position will always be a 1. It's going to be a placeholder. So based on everything going on with this patient, we have that case mix weight of 1.6219. Now, let's go back to there. And we know that the primary diagnosis, look at the clinical grouping, is C for Charles. That was the wound grouping. Now, what would have happened? So you wouldn't always put a patient who has just had surgery and put the wound grouping as primary. Something's going on with this patient specifically that requires extensive wound care, but they're not complicated wounds. They're not enough to be complicated, but it's not just the aftercare they're looking at. It's really taking care of these surgical wounds as the focus of care. But if we had not recognized that, or we didn't know from a coding perspective, we hadn't fully investigated that focus of care, then if we had used just the aftercare code as primary, you'll notice the second position, the clinical group now says G, which translates to MMTA surgical aftercare. Then our case mix weight dropped to 1.4535. So it dropped quite a bit. So that, equates dollars when you calculate that out. Okay, so let's look at this particular patient. This patient was referred. He had a diffuse brain injury with loss of consciousness, okay? So and in addition to that, we've got a sprained knee, fractured right and left shoulder, diabetes, thyroid problems, and multiple other issues. So the source and timing is going to be a 2. It was institutional and early, so that's going to give us that higher points there for sure for that first clinical grouping. And remember, this is only for the 30-day period we're looking at. Then you've got on this next patient, on this next part, you'll see where the functional level is low, A, then the comorbidity adjustment is 1, so there's none. So there's no diagnosis here, and if you'll look to the right where it says comorbidity subgroup in pink, the clinical grouping is in neuro rehab, and then it shows the rest of the codes that could have been primary, but it's not appropriate to have those primary because that's not the original focus of care. Then you've got comorbidity subgroups. So there's nothing here that is going to get us any type of comorbidity adjustment. And so our HIPS code ends up being that 2BA11, translated to the 1.3729. So one of the things I wanted to mention with this same grouping is that this documentation does not reflect that the patient had been diagnosed with neuropathy. So E1140 or E1142 fall into the Neuro 10 comorbidity group and would have increased the case mix weight. Another thing to consider on this patient is that the functional score represents the low functional impairment, if you'll notice that under that functional impairment. But yet the patient had multiple traumatic injuries, including a traumatic brain injury. So this is one of those ones where you would consider looking at the OASIS for accuracy on this patient. Do we truly have in position number 3, where it says 2BA, A representing a low functional level, is that truly reflective of what's going on with the patient? Okay, let's look at another one. I know we've got about 10 minutes here left, so we'll get through these and wrap up with some PDGM tips, and then again give y'all the opportunity to email any questions I might not have covered. So the comorbidity adjustment. So this patient, the primary diagnosis is anemia. We've got ischemic cardiomyopathy, hypertensive heart, CKD, and then we're managing some type of IV device and giving IV therapy of some kind. So looking at this patient, you've got number 4, which would be institutional late. It falls into that K clinical grouping, which is MMTA infectious disease. The anemia code puts it in that infectious disease as primary. You've got a medium functional level. You've got a comorbidity adjustment, the 3 in the 4th position representing high. And so the HIPS code 4KB31 equates to a 1.3035 case mix group. So this patient falls into a high comorbidity grouping. There would be no additional diagnosis that you could add to this patient to affect that case mix weight here. Okay, I wanted to point this one out. This particular patient, we're doing changes for a surgical wound because the patient had some type of surgical amputation and requires wound as the primary goal, not just observation, assessment, or teaching and training. Even though this patient falls into the primary wound grouping, if the patient had some other type of pressure ulcer or other non-pressure chronic ulcer, that comorbidity grouping, which down here is a 2, would have fallen into the high grouping, just to kind of see how things interact. So this patient had an ulcer of esophagus with bleeding, K22.11. Based on all of the diagnosis and what's happening with the patient in the 4th position, it's a 2, so it's a low comorbidity adjustment with a case mix weight of 11867. Now, let's just say if the patient, for some reason, in the documentation, you notice that the patient had, or at least the patient tells you they had a previous stroke and are having some weakness in their right hand, but you don't call the physician or confirm that or do anything else to further investigate that comorbidity that could potentially affect the payment. If you had that previous stroke confirmed, that comorbidity adjustment is going to be, would have brought you up to a high grouping, and instead of the case mix weight being the 1.18, it would be 1.28. Now, what does that mean in dollars and cents? That base rate would have gone from, I don't want to get you confused on that other slide, but basically instead of being 1.18, it would be 1.28, and then when you calculate that out, that's going to be additional additional funding for sure. Okay, so on this next slide, one of the things I wanted you to look at particularly, even though we're talking about comorbidity adjustments, high and low, and that type of thing here, I wanted to be sure you were aware that how much of an impact that M1033 can have. So if you're not marking those correctly, now remember, on this risk for hospitalization, responses 1 to 7 are going to contribute to functional points. When 4 or more are selected, 8, 9, and 10 don't contribute. So if the patient had a fall or intentional weight loss or multiple hospital stays in the past 6 months for this particular patient, then that would have added 11 functional points by just a couple of clicks, and would have increased the case mix weight for this particular patient right here, it's still the same one we're looking at, to 1.34. So if you take the base rate of 1864, which would have been the base rate for 2020, for that 30-day billing period, you're looking at $2,200. Now, 1864, so we've gone in and we've looked at our records and our hospital stay, and we've got, if you'll notice over to the right where it says which ones we've clicked, I've got the top and the bottom. So if you've got 5, 6, 7, 8, 9 checked on the top, and then you've got 3, so 1 click increased that adjustment, and you've got an additional $288 per 30-day episode. So it's just, I want you to take this information back and to really just understand what that means to your agency and how important every piece of the clinical grouping is a part of PDGM. So it's not just, yes, it's where the patient came from. Are they community? Are they hospital? Early, late? And you've got to have a good mix of that. If all you're getting is community referrals, then you're going to leave money on the table letting another agency get all the hospital referrals, because it does make a difference in that adjustment. If your coding's not accurate, if your OASIS assessment is not fully, completely reflecting what's happening with the patient on those payment questions, then it directly impacts the dollar. So my goal really was to get you to kind of understand a piece of that, and then where to look moving forward. So I hope I haven't just given you problems with no solutions, but have given you some thought process to go back and make sure you truly are educating and your staff understands not just certainly the OASIS assessment, but looking at that coding. I had a particular agency I was working with this week who called me for a consult and said, okay, we really need anemia not to be primary. We've called therapy in for this patient and for this new research, and we need some additional help with this, and we really want neuropathy to be primary. Well, neuropathy could not be primary based on just the documentation that I had, because it's unspecified. That particularly neuropathy code that they had given me the information for is not approved for primary clinical grouping. I did say, however, look, if you don't have any other cause listed of the neuropathy and you want to contact the physician, then you've got a diagnosis out there, idiopathic peripheral neuropathy, that is primary and will put you into one of those higher clinical groupings versus keeping the patient with anemia, which really wasn't appropriate for what the goals were for this patient. And so lo and behold, I contacted the physician. The physician confirmed that yes, there was nothing else that would be causing that neuropathy, and that would be a more appropriate code. So things like that to think out of the box a little bit. And so if your agency doesn't have someone that you partner with for coding or someone to look at with that, it's really important for your agency to identify that. Okay, let's finish up here with a few success tips. Again, thank you for being patient, and I do apologize. I hate being on a live session with and having a good old Texas allergy attack, but I love this slide. It talks about financial benchmarks. It tells you what the best case scenario, what it should look like, that when that OASIS is completed, when it should be the coding done and out the door, and to move forward like that. The other thing I want you to consider, if you have not already, is focus of care meetings. So has your team established some kind of process for identifying potential diagnosis or focus of care changes for the second 30-day period billing cycle? So you might want to consider a 3-week focus of care conference, and it can be obviously however your agency functions via phone to determine, do we still have the same focus of care for that second benefit period? Because remember, you can change the primary diagnosis so that it will reflect in that second billing period, which would change your clinical grouping and potentially gain more income for that. The other thing is to consider allowing your QA or marketing personnel to attend these meetings. Do they really know what's going on with your patients? Can they take that back to Dr. Jones? Dr. Jones, we have seen this patient. Here's how she's progressing with therapy. Here's where we anticipate what's going to happen. Who do you think is going to have confidence in when building those referral sources if you're doing what you're saying you're doing to help these patients and not just communicating back to the physician who has certified that this patient is appropriate for home care? So definitely something to look at for sure. So do you have a good quality review process? Are those primary and comorbid codes reviewed, validated? And we've talked about this. Do you have a good system for coding within your agency or a good outsourced company that you use? Do those relate to the plan of care and support the need, medical necessity for home healthcare services? And are those diagnoses pulling to the claims correctly? Because remember, we're not billing off of the OASIS assessment anymore. It's actually coming from the claims data. I like this list of secondary diagnosis codes. And you're welcome, obviously, to take this to a physician or to a referral source and educate them a little bit because it's just a quick little list of, what you could not use and are still unacceptable primary codes. How many patients do you get referred, again, for low back pain? Well, we need to know what's causing the pain. I know we're fighting the rheumatoid arthritis. We really need that one to be back primary. And certainly, multiple other codes here that you want to consider because there are alternate things that you could suggest to the physician on that. And I think no matter what we do at the end of the day, it's working as a team and being collaborative, remembering that there's a patient at the end of all this paperwork and all of this codes. And if you treat a disease, you're going to win sometimes, you lose sometimes. But if you treat that person, then I guarantee you're going to win no matter what the outcome is. So here is my information. Any questions, feel free to shoot me an email, and I'll be glad to respond to that and get anything back to you that you need. And I appreciate the attentiveness this afternoon. And back to you, Heather.
Thank you so much, Nanette, and thank you for our trip around the world. I really enjoyed your facts.
Thank
you. Thank you for sharing your expertise and wisdom. Now, don't forget, attendees, we will email everyone a link to the slides, and we'll also post the video recording of the webinar, as well as post them on our website, axxess.com. So look for that there. Thank you all for joining us today and helping us as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a great day, everybody.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.